All right, let's switch gears. We have been talking about the latest wave. I would say that probably one of the previous wave, or the previous wave, at least from a phase 3 point of view, was, almost within 10 years of the initial reports of EGFR mutations, which was 2004. We had a number of different trials that looked in EGFR mutants comparing chemotherapy to one of the TKIs, and it established a new standard of care in this setting. Initially, at least in the US, for us, for the longest time, some of us go back to gefitinib days, but for the longest time we only had erlotinib.
Look at me. You got gray hair too, man.
I do.
Yeah, I've used gefitinib.
We had erlotinib, and then in the span of a couple of years, we get afatinib, and then we have gefitinib come back after this absence for over a decade or so. So I guess one of the questions I want to start off with, we've seen some recent data from LUX-Lung-7. It's really to date, the only comparison we have in the public domain that compares a second generation agent, afatinib, to a first generation agent, in this case, gefitinib. Your views, is afatinib a better drug?
Well, I probably had to eat my hat after I bet Boehringer that I didn't think the study was going to be positive. But let's explore what a positive study is.
Well, that's a good point.
So when you look at the PFS curves, really they stay pretty similar. And what happens is there's a little longer tail on the afatinib arm. And so what's positive is the hazard ratio. The median didn't shift.
Right.
And what I think that's telling you is that maybe there is a slightly broader spectrum action of afatinib. We know it hits other family members. There could be a mechanism of acquired resistance that you're suppressing. Does this mean this is the solution for everybody? The answer is probably no. And certainly we know the toxicity is greater. That study has not changed my practice. So if you have an EGFR mutation in the absence of the FLORA data, you're still, in my practice, going to start on erlotinib.
Mark, your thoughts?
Yeah, I think, and I think Ross was alluding to this, it depends on goals of care. For a small benefit and more toxicity, is it right for that patient? And for certain patients it's right, and for many patients it's not. And I mean, that's how the decision is made. I think the data is there that it's a little bit better, but it's not a lot better, and it's got more toxicity, absolutely. By the way, though, there is a lot more flexibility with the dose. I think all of our targeted therapies, with rare exception, have been dosed in wild-type patients, right, for the phase 1 at least, and there's a lot more flexibility there. However, it's more toxic, and it's not right for every patient. I think we're in agreement here by and large.
Yeah. So we know that there's going to be a study at ASCO of dacomitinib versus, I can't remember if it's erlotinib or
erlotinib. Yeah.
So we're going to have another.
I think it was gefitinib. Was it erlotinib?
I thought it was erlotinib.
Oh, but
well, we'll see. So that's a late breaking up. So we're going to see another second generation versus first generation, see if there's a similar story.
Right. So let me ask the panel, you have an exon 19 deletion mutation next week in your clinic. David, what are you going to use?
It's funny because our pathways like us to use afatinib, but I use erlotinib.
Ross?
afatinib, bevacizumab.
That's the next question. Jared?
Gefitinib.
You asked.
Gefitinib. Okay. All right. In exon 21, L858R?
Same
Any
answer.
difference?
Same.
I mean,
We
that's the
agree on
one
same
thing.
answer, at least.
But that's the one thing in LUX-Lung-7 that impressed me the most was in the exon 21, the response rate, 70% versus 45% or something like that. I was impressed with that. So,
But chemo was better in those arms.
But
I don't think anybody's going to go back and give chemo to these
yeah,
people up front.
yeah,
So I think we're all in agreement. We would give whatever we'd give to 19s to 21s.
Right. So getting back to Mark's comment, we saw in a Japanese trial a very positive impact on PFS of adding bevacizumab to erlotinib, I believe. It's been published. I think we've seen survival, no difference as of this point yet. I think.
I think that's correct.
Yeah, PFS is the only data I've seen.
Right. Mark, your thoughts on that data? Is this something you do?
I do it in every patient where bevacizumab would be safe, yeah. Because, again, give your best drugs up front, the greatest duration of benefit. Nothing for a patient has greater meaning usually than that first disease-free interval.
But getting back to your goals of care, but doctor, do I really have to come every 3 weeks and get an IV put in and get an expensive drug that I have a high copay on?
Again, I would hope that obviously, I hope, I know all of us make choices with that patient in mind. And for some people, it's not right. Some of the side effects, you could see somebody who loves to sing, they wouldn't like the hoarseness, and that might not be a good drug for them. That's what happens. But I would recommend it unless there's a reason not to do it.
Jared, your thoughts?
I think that's a reasonable way to think about it. I think about it a little bit differently in the absence of a survival advantage. What I love the most about the oral TKIs is the demedicalization of the patient's life. So to your point about, do I have to come to the infusion room every 3 weeks? You combine drugs with greater efficacy than doublet chemotherapy for that population. So the patient's going to have less cancer-related symptoms. Fewer side effects than cytotoxic doublet chemotherapy, although not side effect free. And then the oral, all these come together to a more normal life. And I really hesitate to take that away from the patient in the absence of a clear survival advantage. I think it's a reasonable thing to think of for a motivated patient, but it's not something that I reach for commonly in my practice.
But I challenge you to ask your patient next time, if you knew your cancer will come back 6 months faster by doing this, is it worth it to you to come?
It's a very fair question. The counter challenge would be that if you directly told the patient you will derive no survival advantage from this, and we're in an era where for the majority of patients we now have second-line TKIs, do you really still want to do it? Probably we'd both get some surprising answers from our patients.
I mean,
it leads to personalization and involving patients in decision making.
The other question is, the patient could say, Dr. Kris, could you tell me where I am on this PFS curve?
Yeah.
Which one of these is that? Am I on the tail? And you don't know for that individual patient.
Well, that one you never know.
I mean, these are philosophic differences in looking at the same data, and different patients will choose different things if we counsel them properly.